All right, face and neck injuries. These injuries are pretty common, but that doesn't mean that they're not life-threatening. Your penetrating neck trauma can cause severe bleeding because you've got some pretty large blood vessels up in your neck. Open injuries can also allow air embolisms to enter the circulatory system, which will kill you. And these injuries can slow and even stop blood flow to the brain. Like I said, there's those great vessels that are in your neck. And several of them, their main job is to push oxygenated blood to your brain. And obviously, if there's anything impeding that, then that's going to slow that down and cause either death or deficits. Yay. Overall treatment objective is to make sure that we're preventing further injury, especially to the cervical spine, that we're controlling bleeding and managing the airway. What I say. It's pretty much the management for all trauma. So, alrighty. The face is made up of 6 major bony structures. Does anybody know what they are? I'll give you brownie points. I will praise you. Anybody?
Mandible is the one you're circling.
This one?
Yes.
Yes, the mandible.
Above
Brownie
it,
points for
zygomatic
you.
bone.
What?
Above it, the zygomatic bone.
Zygoma, yes, right here. Anybody else? Anybody else know anymore?
One of them isn't it the maxillae?
Maxilla, right here, yeah. Maxillae, I think, is the plural, because technically you have 2, one on each side. But yeah, the maxilla. There's a couple more.
Frontal.
The frontal, right here.
Orbital?
No.
Parietal. No?
Your parietal is, they actually don't do a really good job of showing it. It's like, they actually do a terrible job of showing it. I think it's technically this one, but it comes down too far in the back. So not quite your parietal, because we're just looking at the face. We've got the mandible, the maxilla, the zygoma, and the frontal. There are 2 more. Technically.
Nasal bone.
The nasal bones. Good. I'll save you from your suffering. So we've got our nasal bones, okay?
Technically, your teeth are bones, so your teeth.
All right, that's fair. I'll give it to you. It's not on my my fancy slideshow here. Um, but that's fair. That is on your face. Okay, so your nasal bones, your zygoma, your maxilla, your mandible, technically your occiput, up here, that's gonna make some of your, I think technically right here is what they're counting towards your face, I guess, which is part of your occiput, although your temporal is much larger than it says it is. And then it's not really a bone so much as it's a structure, but it's your temporomandibular joint, otherwise known as the TMJ. Anybody been told they have TMJ problems? TMJ problems are the worst. I grew up with TMJ problems. I locked my jaw in place. I couldn't open my mouth more than a couple fingers for like 3 years just from chewing gum. So that sucked. And then just one day it went back to normal. So there's that. Fixed itself. I'm very loosely put together, I feel. Okay, somebody mentioned the
What was the
orbit.
back of the head?
What?
What was that back top of the head part?
So this, like I said, their drawing is kind of lame. So you've got your frontal, your parietal, your occiput, and your temporal bones. So, ooh, will you grab me the skull we have? Thanks. I'll show you one that's a little bit better. Hopefully. Yeah. Thank you. Okay. Does everybody see that? Yeah, yeah. Okay. So I'm going to try and do this. So your occiput actually comes up further than this diagram shows, or this picture. So this in the very back is your occiput, and you can actually feel a notch on the back of your head, and that structure is called your occipital protuberance, I think. I think that's what that's called. Anyways, you have one occiput, and then you have two parietal structures. So one on one side, the other on the other side. And then you have your frontal structure. I'm not doing a very good job of trying to block it from you guys. Anyways, your frontal structure and then your temporal structure. Okay. And so then you have your zygomatic bone, and then your maxilla, then your nasal bones, okay, and your mandible. All right. There's actually like 6 billion bones. This does not do it justice. I should have brought up my anatomy notes that I took, because there's like 1 billion structures in the skull alone. That there's just so many things. Anyways, but those are the main ones that make up the face. And then we were just talking about that TMJ, and that's the joint that allows our jaw to move up and down. So that's kind of nice. Does that help? Hopefully. Okay. So somebody brought up the orbit. The orbit isn't so much like its own bone as it is the actual eye socket. There's an orbital floor that's made up of a few different bones. But the eye socket in general is made up of the lower edge of the frontal bone, okay, the nasal bones, the zygoma, and then the maxilla. I put those in kind of wonky order. It's kind of, so this is like more the zygoma, and then this is the maxilla. I was exploring a new part of Canva when I made this. Anyways, but that makes your orbit. It also creates the orbital floor. Okay. No. All right, hang on, wait. I have to reload this now. Okay. Your larynx and your trachea. So your larynx is this big structure right here. Okay. It's got all of these not checkpoints, like orientation, just points to orient you. So this is the larynx, and then your trachea starts at the bottom of your larynx and then goes down to your carina, and then to your primary bronchi, secondary bronchi, bronchioles, and alveoli. Okay. So, but your larynx you can feel in your neck, and it actually feels funny. Some people will stick their finger down their throat to make themselves throw up. All I have to do is move my larynx back and forth and it'll make me gag. But the biggest part is the laryngeal prominence. This is what makes the Adam's apple. This is genetically bigger in males than it is in females. And then going down from that prominence, you find this edge here, and that's a really good marker for feeling your thyroid cartilage, okay? Your thyroid cartilage is like this bony structure. It's not a bone, but it's a tougher structure. And then your cricoid cartilage is smaller and comes just beneath it. And these two things are joined by your cricothyroid membrane, okay? Yeah, your cricothyroid membrane. So they make it pretty easy to remember. You just have to remember that your thyroid cartilage is on top and your cricoid cartilage is on the bottom and it's smaller, okay? And then you move into your trachea, all right? The other structure that's good to know is your hyoid bone. It's kind of this floating bone in your larynx where the cartilage attaches to. There's some muscle that attaches to it as well. And so all of those attachments that then attach to other things are what keep that hyoid bone in place. But that hyoid bone is an important part of keeping everything together. It's like I feel like it's like a hub for a bunch of different connections. Okay. All right. So if we take that and surround it with our muscles, so we can see our cricothyroid membrane that's here in between our cricoid cartilage and our thyroid cartilage. And then right here is our hyoid bone that everything's attaching to, okay? You can see your carotid arteries and you can see your veins, your jugular veins, all right? And then your trachea, okay? And the biggest muscle right here that surrounds these is your sternocleidomastoid muscle. Okay, so let's break that down a little bit for the sake of medical terminology. This muscle is named after the three places that it attaches to, the three bones that it attaches to. Can anybody guess what any of them are?
Have the
Sternum.
sternum.
Yep, sterno is sternum. What about cledo? That one's kind of
clavicle.
your clavicle. Very good, Weston. And your mastoid.
Your jaw.
Close. It's your mastoid process, which is right here on your skull. So it's kind of next to your TMJ, but your mastoid process is right here and it connects there. So it goes, that's what you see right here. It's going to connect up here to the mastoid process of the skull and then down to your sternum as well as down to your clavicle. This is the big massive muscle that you can see in like weightlifters, or you can see it in a lot of different people actually. But if you are like me and admit to being a bit of a nerd when it comes to anime, I am, and I hope that doesn't change your opinion of me. If it does, I can't control that. But one of my favorite is Attack on Titan, and the protagonist is Eren Yeager, and he has fantastic sternocleidomastoid muscles, and you can always see them. Somebody at some point said, "Wow, look at that jugular vein," and I was like, I will weirdly flex on that. That is not a jugular vein. Anyways, but that is always what I remember about the sternocleidomastoid muscle, is it's really great on some anime figures. Okay, so those are the muscles that that's the main muscle in the neck that they want you to know. There's like a million other muscles. There's little ones that just go and connect or swing around your hyoid bone. But the sternocleidomastoid muscle is the main one. So, okay, moving on to the eye. There's a few parts to the eye. I want to kind of break it down for you in the anterior compartment and the posterior compartment, okay? So your anterior compartment is everything anterior to these little muscles here, your ciliary muscles, and those muscles control the contraction of your iris, which then controls the size of your pupils. So when they are contracting, your pupils are very dilated. And when they are relaxed, your pupils are very constricted. Okay. Does somebody remember what one of the telltale signs of opiate overdose is?
Pinpoint.
Pinpoint pupils. Because opiates relax those nerves, which then just causes your iris to just cinch because everything's relaxed, nothing's contracting, right? So they're really, really small. Whereas if you are on a stimulant, it's going to cause those muscles to contract, and so you'll have pretty dilated eyes. Okay. So you've got in your anterior chamber and your posterior chamber. So you've got anterior here, which is where I want to make sure that I'm saying this right. It's like your cornea. And then there's your iris, and then there's your posterior chamber, and then your lens. Okay. And then your pupil is not a structure, it is a hole. And it's because of that hole that light can come in and allow us to see. So light comes in through the lens and it hits the fovea, which is covered in rods and cones, which then gives everything distinct lines and colors, which then talks to our optic nerve, which talks to our brain, which allows us to see things, okay? Corrective lenses are literally just that. The reason why people have bad eyesight is generally because the cornea is misshapen. And so it refracts the light incorrectly, so it hits somewhere other than the fovea. And the further away, or depending on the angle, depends on whether or not you're nearsighted or farsighted. Okay. And so corrective lenses fix that angle so that now the light is coming in at the correct angle and hits the fovea so you can see clearly. Isn't that fun? Fun fact. The anterior compartment of the eye is filled with aqueous humor. Okay. It's a fluid. It's kind of like a jelly-like fluid. And the posterior is filled with vitreous humor. Okay, that's an important thing to remember the difference. Aqueous for anterior, vitreous for posterior, or ventral. No. Wow, that looks really bad. Posterior is vitreous. There are 3 layers to the eye. You have the outside, the white is the sclera. Okay, that's the layer that everybody can see. Then underneath that is the vascular layer, which is your choroid. And then underneath that is like your nerve layer, which is the retina. And that's what the light hits through the vitreous humor. Okay. And then there's your optic nerve. And then the vasculature that goes into your eye. Okay. All right. Surrounding the eye, we've got obviously we've got our pupil and our iris, but you want to understand about the conjunctiva. The conjunctiva is a layer that covers your eye and the inside of your eyelid. And I want to explain, so if we go back here, there's like a little mini layer that kind of comes off here. That's acting like your conjunctiva. If you imagine that there's an eyelid right here, your conjunctiva comes here and then it swoops around and layers the inside of your eyelid. And so for people who are scared that contact lenses are going to go up into the back of their eye, it quite literally cannot. Just like COVID tests up your nostril aren't going to poke your brain, because anatomically it is impossible. Okay, unless there is a laceration in your conjunctiva, that acts as a protective layer from any debris or foreign objects getting stuck in inside the eye socket. Okay. Everybody's heard of conjunctivitis. That is literally an inflamed conjunctiva. Conjunctivitis can occur from infection or trauma. Okay, the infection that we've heard it mostly from is pink eye. But trauma to the eye directly can cause irritation and inflammation of the conjunctiva. So you will see it outside of that infection as well. Your lacrimal glands help keep your eye and eyelids lubricated so that they don't dry out. And then your nasolacrimal ducts these are your tear ducts, okay? And they go into that little, it's like that little mini ball of, I don't know, spongy ball of flesh or something. That sounds gross. But yeah, that's where your tears come from. And the way that your eyes blink is they blink from medial to lateral, which then pushes the tears across the eye. And that's why your tears usually come out this way. Fun fact. Okay. Any questions about the eye? Awesome. Things to know, your eye socket is also called your orbit. You have 12 cranial nerves that innervate your entire body, and 2 of them are dedicated specifically to the eye. Okay, there's cranial nerve 2, which is your optic nerve. This nerve is what makes it possible for you to see. So that is the nerve that is receiving signals from your fovea and the rods and cones there. And then your oculomotor nerve is your cranial nerve 3, and that innervates the muscles surrounding or attached to your eye that allow you to move it back and forth around. It allows people to roll your eyes. Anisocoria is the condition of unequal pupils. Generally speaking, most people have identical pupil size. But there are some people who have unequal pupil size. I had one patient once who had unequal pupils. And I remember sitting there and just being like, she hasn't had a fall. She hasn't had, like, there's no signs of any kind of bleed, but she has these unequal pupils. And come to find out, that was just something she was born with. So, and then we already talked about the conjunctiva. Give me 2 seconds. I have to let my dog out. She's driving me crazy. Okay. Sorry, she was staring at me expectantly. Okay. Talking about the nose. The important structures here to remember is that you have pairs to just about everything in your nose, except for the septum. Your septum is supposed to go, excuse me, is supposed to go directly in between. But if you're like I am, you might have a deviated septum, which then makes it really difficult for you to breathe. Where your septum comes too far to one side, so you have a smaller nostril than the other. The other thing is you have turbinates in your nasal cavity, and these turbinates are why we can smell. Your olfactory nerve innervates in the nose and makes it possible for your brain to register smell. And they get a lot of their signals from your turbinates. The reason why like dogs have a keen sense of smell is because they have tons of turbinates. We only have like 3. They have like, I don't know, like 20 or 30. They have tons. So they have a much better sense of smell than we do. The other thing to keep in mind is that your sinus, you have a frontal sinus, and then you have a sinus posterior to your nasal cavity. These can be greatly affected with barometric energy, okay? And they can be affected in blast injuries, basically anything, because they're technically hollow. And so they can be susceptible to pressure change. That's why a lot of times, like when there's a storm or when allergy season comes, there's a buildup of pressure in your sinuses, so you'll get a sinus headache. Because, you know, if you're allergic to something, then excess fluid is going to get built up in your sinus and cause a lot of pressure. Okay, the ear is one of my favorite things. This is the auricle. This is the piece of your ear that you can feel and touch and pinch and move and all the good stuff. The anatomic term is your pinna or your pinna. Your external ear is comprised of your pinna and the external auditory canal, okay, your ear canal. This is all considered your external ear. It becomes your middle ear once you hit the tympanic membrane, okay, right here. And your middle ear has your tympanic membrane or your eardrum, and then it has 3 teeny tiny bones called ossicles. And those are your malleus, your incus, and your stapes, okay? And the way that these are put together is it's almost like they're on hinges. And so something, you know, a sound wave hits your eardrum, and then it causes the malleus to move, which causes the incus to move, which causes the stapes to move. And the stapes is then connected to your inner ear, okay? So the cochlea and the vestibules, okay? And so that movement here from the vibrations of the tympanic membrane get transferred to our vestibule and our cochlea, and then connected with our vestibular nerve. That is what allows us to register sound, okay? This tube down here, this is the eustachian tube. A lot of times, people will get ear infections, and it will cause fluid buildup here in the eustachian tube, and it becomes infected, okay? Inner ear infections are rare. So if anybody says, yeah, I've got an inner ear infection, 9 times out of 10, they actually have a mid-ear infection right here. There's a much more common. Yeah. Any questions about the ears? Phenomenal. I know this is super boring. But now it's not boring because we're going to talk about injuries. Yay. There's dinosaurs. I think they're cute. I don't know. I was in a funny mood in the middle of the night. Okay. Speaking in general, injuries to the face and neck can partially or even completely obstruct the airway. Okay, so you think about your access to air. You get that through your nose and your mouth. And if you have facial trauma to your nose and or mouth, that can obstruct your ability to breathe with blood, secretions, teeth, just the movement of bony structures can make it difficult. Swelling that's accompanied with injuries to the soft tissue can inhibit your airway. And then neurologically, your cervical spine and brain injuries can hinder your ability to breathe. Okay. Specifically with soft tissue injuries, so the adipose tissue or the tissue making your skin, these are pretty common, but that doesn't mean they aren't life-threatening. Okay, their presence may point to a deeper, more serious injury. Okay, and watch out because these areas are extremely vascular. So don't get tunnel vision. These areas, your face, your head will bleed a lot, but it's because they're vascular. That doesn't necessarily mean you shouldn't stop the bleed. You should. But keep in mind that it may not be the most serious or the most critical of the patient's injuries, okay? So don't get overly focused on that one aspect of an injury. When we treat and manage soft tissue injuries, we of course want to make sure that we are continually protecting the airway. So from those secretions, that blood, any debris, we manage their life threats first, okay? And then you manage their ABCDEs, okay? Or your ABCDEs. I don't know. I think that's funny. But life threats have to come first. Now, your life threat may be one of your ABCs, but it needs to be managed first, all right? Securing and maintaining their airway, we need to make sure we're taking necessary precautions to protect the cervical spine, like using the jaw thrust maneuver, okay? If there's any suspicion of spinal injuries, particular to the cervical spine, we need to make sure we're using the jaw thrust maneuver on our patients in order to not exacerbate any injuries, okay? And then, of course, we do want to control the bleeding. Look, we did all those things for our dinosaur friend. He has a C-collar, so his cervical spine is stable, and we controlled the bleeding on his face, and we used some gauze. He's in good shape.
That's awesome.
Thank you. Took a lot of arts and crafts. Other things we need to do is cover the exposed tissue with moist, sterile dressings, okay? We want to make sure we're checking for bleeding in the mouth or displaced teeth, and any avulsed skin, if separated completely from the face, needs to be in sterile dressing and placed in a plastic bag in a cool temperature, not on ice, okay? Just a cool temperature. If it's not separated completely from the face, we want to try and put it back as close to normal as possible and then dress it with moist sterile dressings, okay? Do we all remember what an avulsed skin is? It's like being scalped.
It's when the
Or-
skin is pulled off,
Still,
or
yeah.
often referred to as like degloved.
Yeah, yeah, just like that. And it can be partial or it can be complete. So it's very gross. I decided to not put avulsed skin pictures in here. If you're really that interested to know what it looks like, feel free to Google. Okay, facial fractures occur when our facial bones absorb a strong impact, okay? If the maxilla is fractured, that's that top portion of our mouth, then there will be closed head and cervical spine injuries. If the force was great enough to fracture your maxilla, then there are many hidden and there are other hidden injuries due to that amount of force, okay? So it becomes imperative for us to monitor neurologic signs, especially the level of consciousness. And things that can point us to that direction are any deep lacerations, pain over the bones, ecchymosis, crepitus, misaligned teeth, and of course, impaired vision and ocular movement, okay? Facial fractures alone are not acute emergencies without serious bleeding, but excessive bleeding can impede the airway, and facial trauma can indicate deeper, more serious injuries, okay? Plastic surgery surgeons can fix structural issues if treated within 7 to 10 days of injury, okay? So it's not acute, but it can mean that there's something worse happening on the inside that is acute and emergent, okay? So just the same as the others, protect the airway, control the bleed, and continue reassessing every 5 to 10 minutes. Swelling can become a problem, okay? Specifically with a zygomatic fracture, that's this portion right here, your cheekbones. Your face appears, the face will appear flat on the impacted side. This is a common injury in car crashes, as well as assaults or domestic violence calls. Obviously, there's going to be loss of sensation in some areas, but particularly in an upward gaze, okay? So looking up, we're going to have a loss of sensation there. And then other injuries to be aware of are orbital, ocular, and epistaxis, okay? Epistaxis, anybody know what that is? I had to look it up.
That's a nosebleed, right?
It's a nosebleed. Nice job, Glenn. Yeah, epistaxis is a nosebleed. We'll talk a little bit more about that in a bit. Okay, dental injuries can be isolated or they can occur in conjunction with maxillofacial injuries. Always assess a patient's mouth when you suspect a facial injury, because if they have a facial injury, there's a high probability that there are dental injuries. And dental injuries can impede the airway, okay? We want to make sure we're removing loose teeth or dentures to protect the airway. Avulsed teeth should be handled by the crown, not the root. But we don't want to allow the tooth to dry. So wrapping it in moist, sterile dressing and then in a plastic bag and label it so you don't lose it is a good idea. Any well-fitting dentures, we need to leave those in place. It'll do probably more harm than good to remove them. Any suction, we need to keep it handy. Dental fractures or injuries will likely mean blood secretions, things like that. And then controlling any bleeding as well as we can. For severe oropharyngeal bleeding, so your oropharynx inside your mouth, in patients with inadequate ventilation, we want to make sure that we suction the airway for 15 seconds and then we provide ventilatory assistance for 2 minutes, okay? In advanced airways, if you have one, then usually you can kind of do both at the same time. But if you're just bagging your patient, they need air, but we also don't want them to aspirate on fluid. So it's kind of an equal alternation of the two, okay? Any impaled objects, unless it's compromising the airway, need to be left alone and stabilized, okay? The longer it is or the bigger it is the more important that we stabilize it, okay? Create counter pressure if possible by packing the buccal cavity, so inside your cheek with sterile gauze, but we do not compromise the airway, okay? So you can pack the inside of the cheek with some gauze. that will give you some counter pressure if maybe they have a laceration that's bleeding really badly, or you're trying to wrap around the nose or the head or things like that. Okay. Nasal fractures are the most common of your facial fractures, obviously characterized by swelling and crepitus. These often appear as a lateral displacement of the nose, because usually it's just your septum that's been fractured, but your nasal bones can be fractured too. And then you're going to see nosebleeds, either anterior or posterior, and those can complicate this injury because now you have to deal with suction as well as a possible hemorrhage. Okay. Okay. With our nosebleeds or epistaxis, these are either anterior or posterior. Our anterior bleeds, which are more front, these are usually less serious and they bleed slower. And usually easier to staunch. Okay. Your posterior nosebleeds are more severe, mainly because they drain into the patient's throat. You have a lot of vasculature on the surface of your nares, particularly next to the septum, which is why when we insert NPAs, it's the bevel side in, so that we're not carving against the septum and causing a nosebleed with the point of the NPA. Okay. We also want to make sure that we are registering the color of the secretion. Okay. Is it just blood? Does it look a little diluted? Because CSF can, we normally associate it with draining from the ear, but it also can drain from the nose. So making sure that we are aware of what's happening, that way we can be clued into other more serious injuries such as a basilar skull fracture. Okay. Okay, obviously leave impaled objects, create counter pressure. This is all the same. We just want to stop the bleed and we want to maintain the airway. For epistaxis emergencies, pinching at the nares is most effective, okay? And I say check your placement because if you put your fingers up here on your nasal bone, that's going to do absolutely nothing. Your nasal bones are a hard structure. You're not pinching off anything. If it's a posterior bleed and you pinch down below, all that's going to do is make it easier for the blood to drain into your throat. And blood is a gastric irritant, okay? It irritates your stomach. So we do not want that. For posterior bleeds, it's better if you find your nasal bones and then you go just to the very first soft part in front of it. Okay. And that is going to give you the best placement for pressure on your posterior bleeds, as well as your anterior bleeds. Posterior, depending on how severe they are, might need to be cauterized. I've seen it happen. It always kind of sucks when you have to go to the emergency room because you have a nosebleed though, because then everybody judges you. But nosebleeds that last longer than, honestly, I've heard different, 20 to 30 minutes should be seen as an emergency. Okay. Any abrasions or lacerations, we want to make sure we're controlling the bleeding with direct pressure with a sterile dressing. No surprise. Mandibular fractures, your jaw. This is if it's fractured, it's most commonly at the angle of the jaw. Your patient's not going to be able to open their mouth. There's going to be point tenderness and pain. This can also just be a dislocation at the TMJ. Okay. You can have a dislocation from here. And that's going to cause some of these same symptoms. Okay, maxillary fractures. There's 3 types. There's Lefort 1, Lefort 2, and Lefort 3. They made it super not complicated for us, okay? It's just remembering which is which. So if we look here, we have all three kinds. Lefort 1 is just a horizontal fracture of your maxilla, okay? And that's going to displace or disconnect your inferior maxilla from the rest of your facial structure, okay? Your Lefort 2 is going to be a fracture of your maxilla here and your nasal bones, okay? So now there's an even further fracture or separation of facial bones from, or of your maxilla from the rest of your facial structure. Your Lefort 3 are all mid-facial bones, okay? It's straight across the top of your face. And this is going to disconnect your entire face from the rest of your face. So hopefully, again, I don't know if it's hopefully or not, but if it's an open fracture, this can be messy and probably really gross to look at. Okay, so stabilizing becomes really important. Our orbital injuries mostly have to do with the orbital floor. So where your maxilla and your zygoma and nasal bones kind of meet, a fracture of the orbital floor is also called a blowout injury. Okay, and we'll see a picture of that in just a minute. Some signs and symptoms include diplopia, which is double vision, numbness over the eyebrow or the cheek, massive nasal discharge because of the type of injury. Obviously, your vision will be impaired and again, paralysis of the upper gaze, okay? Your pupils can tell you a lot. Normally, they are pearl. Pearl is what? Somebody want to tell me what pearl stands for?
Pupils are equal and reactive to light.
Yeah,
I'm
there's
missing
one.
one.
What's the
What's
other
And
the
part?
other?
round.
Oh yeah, round.
Round. Yeah. Pupils are equal, round, and reactive to light. Okay. And they track together. Um, there are people like oh shoot. Skarsgård, I think he's the guy who plays Pennywise. He can literally make his eyes go two different directions. And I think that's crazy. People can do that, but normally your eyes track together and they should. Because you can cause some serious problems if they don't. An injury to your orbit or your eye is going to likely disturb your eye movement and vision. Pupillary abnormalities are typically a sign of brain injury rather than eye injury. So it's mostly our motor function that will indicate an eye or orbital injury. Okay, if it's pupillary, then we're looking more at a brain bleed or injury. Okay, foreign objects in the eye. If they're small, little itty bitty foreign objects like an eyelash or an old contact lens or just random debris, then we want to make sure that we irrigate. I've had a surprising amount of patients who have had their tires, they're semi-truck drivers, their tires have blown up in their face. And they always have injuries to their eyes from debris as well as possible chemical burns. Just one last week, I had a guy with debris and then a burn to his sclera. And that was wild. But we want to make sure that we try and irrigate the eyes as best we can with sterile saline. This can flush away loose particles. We always want to flush from the nose laterally, okay? Because we don't want to flush anything into the next eye. Anything in your eye is likely going to leave a small abrasion, which is going to irritate the patient. They might make complaints that something is still there. Of course, still assess, investigate, and if there is anything, then you can irrigate again. But if not, you can tell your patient, hey, this is very likely. Just do your best to not open your eyes and move them too much side to side or up and down. Some, oh, I spelled impaled wrong. That's horrible. Obviously, impaled objects, we stabilize, we cover both eyes because we don't want our eyes to track. Like I said, your eyes are supposed to track together. And so if you have one that's injured and the other one is fine and it's looking around, what's the other one going to do?
It's gonna
It's
try to
going
look
to look
around.
around.
Yeah,
Yeah.
it's gonna move too.
Yeah, and that can be a real problem. Okay. We want to make sure that we cover our eyes with moist, sterile dressing, particularly if any of the actual eye is exposed. We want to keep that that area moist and lubricated, because if they can't blink, then there's no fluid that is keeping the eye surface moist. Okay. If it's a chemical burn, we want to stop the burn. Flush the eye with sterile saline solution for at least 5 minutes. If the chemical is alkali or a strong acid, we flush for 20. Okay. And we're going to cover with a moist, sterile dressing. How do we know what kind of chemical it is? Are we always going to know?
No.
No. But what are some ways we can know?
I know there's like pH strips. I don't know if you guys care for that. You can test it, right? If it's around the patient, maybe.
Yeah, I guess. I don't know. I've never heard of that. I
We
know
have
that. Go ahead.
ERG placards on the side of the building, like GH said, and like MDS sheets if we have the actual bottle or something that they're exposed to there.
Yeah, if they have the source, we can figure it out that way. Safety data sheets. If they are in an area that deals with any kind of chemicals, they have to have safety data sheets. We have, I was in charge of compiling all the safety data sheets for everything that we have here on site. And there are so many. And I just did one shelving unit of like cleaning products. And it's like a binder that's this thick. So you can also Google safety data sheets if you know what it is that they used. You can Google it and it'll come up. So, and those safety data sheets will tell you what kind of chemical it is and what to do in case of exposure. Okay.
I have a question.
Yeah.
So if we don't know, do we just err on the side of flushing for 20 minutes? Is that what you typically do?
Yeah. Or for as long as the patient can stand, pretty much. I honestly don't know of a patient who can stand 20 minutes if they're conscious. Because it doesn't feel good. Especially because your natural instinct is to blink a lot. Yeah, and it's never very comfortable. So it's your eye tries to protect itself from anything hitting the surface by blinking and keeping it shut. So not all patients have a very high tolerance for flushing the eyes. Some ways that you can flush, you can use a nasal cannula. You just hook up the nasal cannula to the end of like saline, like a bag of saline, and you can just let it run. And it's nice because it sits on either side of the nose, and flushes the correct direction into your patient's eyes, into and out of. I think probably one of the bummer things is the only way to stop it is if you pinch the line and continue pinching the line, unless you figure out a way to like do that without you having to do it. Lots of laboratories or like chemistry classrooms, things like that will have these eye flushing stations. I always thought you were able to turn these upwards. No, maybe she's just, I don't know. But you can sit directly below it, and these will pour into both eyes. And then of course it will follow the natural pathway of your eye laterally. Okay. You can use just a bottle of saline and pour it directly, or you can be baptized. She doesn't look all too excited about it. The one thing I don't like about this method is that it doesn't the contaminant is contained within this area, and you run the risk of it getting into the other eye. So I would probably not use this tactic, but what I do like is just a gentle flow isn't usually enough to irrigate the eye that has several pieces of debris or anything that's really stuck to the cornea. So I'll use a saline flush because I can control the flow that way. And I can increase the flow to make it a little bit more aggressive to get things off of the surface of the eye and out of the conjunctiva. Okay. Thermal burns to the eye. These require specialized care. If you see that the eyelids are burnt, we provide prompt transport without further examination. We cover both eyes with moist, sterile dressings. Light burns usually are affecting the retina more than anything else. But you can get it with UV light, infrared, eclipse. Sometimes people are stupid and look at the eclipse without glasses. That happened a lot a few years ago. And then laser burns. These are initially not very painful, but these become very painful after about 3 to 5 hours post incident. Okay. This is one of those occasions where you're going to see conjunctivitis that doesn't originate from an infection. Your conjunctiva will become very inflamed, tender, red, and you will be very unhappy. We're going to cover it with moist sterile dressing, and we're going to protect the patient from light exposure, okay, and transport them. Lacerations to the eye. These also require specialized care. We do not apply pressure to the eye at all. You can apply pressure to the bony structure or like the skin if it is supported by a bony structure. So a laceration to the maxilla or the zygoma or the inferior portion of the frontal bone, those can all get pressure, but to the actual eye itself, if the actual eye is lacerated, we don't put any pressure on it. That can cause a lot of damage nerve-wise. We want to make sure we're placing moist sterile dressings over the exposed eyes and cover with an eye shield, a cup, or a sterile dressing to protect from further damage. Okay. This is another one, really any injury to the eye, you're going to want to cover both eyes in order to prevent that tracking that will further irritate the injury. Okay. This one's gross. That's an eyeball. Ugh. I think it's gross.
You didn't show us a full skin, but you showed us an eyeball coming out.
I guess that's true. I'm so sorry. Different things gross me out, okay? Don't judge. Okay, with displacement of the eye, the treatment is the same. We don't put any pressure on the eye. We don't try to put it back. We just stabilize it and prevent further injury by covering it. Okay, moist sterile dressing in order to keep it lubricated. Okay, keep it from drying out.
I've got a question about that.
Yeah.
Would we do the method where you kind of roll up extra gauze and kind of make like almost a ring around it? So it's like, you know what I mean? It's kind of like suspending
like
the
a donut.
bandage over the eye. Yeah.
Yeah. I think that's a good idea as long as whatever is going to be touching the eye is moist. So you can create a donut that way in order to hopefully prevent movement. Um, so stabilizing it as well as giving it a source of moisture. But we will also still want to cover it up with something else.
Right.
So like a cup, or if you carry eye shields or whatever that aren't going to directly touch the
Yeah.
avulsed eye, then we still want to cover it. But I think that's a great idea as long as there's no pressure being put on the eye, as long as you leave enough room on the inside to support the eye, but not push on it. That makes sense?
Yeah.
Cool. If there's blunt force trauma directly to the eye, these can be as insignificant as a black eye to a totally damaged globe. Okay. Hyphema is this right here. It's the bleeding within the anterior chamber. Okay. So in front of the iris, but behind the cornea. Okay. So it will fill with fluid or blood. And that can indicate a spinal injury. Okay. There's real hyphema. You can see it right here. It's kind of dark, but
I
it's
have a
right.
question.
Yeah.
Can CSF be involved in that, or is that just through the nose and the ear?
I think technically yes. I mean, if the stars aligned that the bony, like the sphenoid bone inside your skull, if that were to fracture and um the back of your orbit were to fracture and your conjunctiva were to be lacerated, you could probably get CSF out your eyeball. So, but I think several things would have to line up in order for that to happen. So, um, ew. Daryl, that's nasty. Did you get it put back on?
No, no.
Okay, all right.
What
Ugh.
what
You
happened with
had to
that?
send the nail. Ugh. All right.
Right?
Did you at least save your finger?
Which is funny because that picture is what I sent to my wife when I was trying to explain over the phone while in shock that I had injured myself at work. Because I thought, hey, this picture has the least amount of blood, but apparently that was the worst picture to send her.
Oh, uh, I had a patient with an avulsed finger. So yeah, it was a lot like that, but it wasn't the actual like soft tissue that came off. It was just the layer of skin that included his nail that was like avulsed partially because a blister had formed around the tip of it and then it had ruptured. And so yeah, that was
That's
gross.
crazy.
Yeah,
Daryl,
it's
this
totally
is
nuts.
crazy
So that-
small world. I have the same tip of that finger got cut off about 10 years ago. I've got a nub as
Nice.
well.
Yeah, yeah. So mine happened in a concrete mixer in the hydraulic chutes. It built up hydraulic pressure. It was stuck, and then it decided to have too much pressure, got unstuck, and caught
Oh,
my finger.
oh man. Small world.
My mom's dad, so my grandfather, uh his ring finger on one side, I can't remember, the top of the digit got uh severed, was amputated from his hand. I still 100% do not know why. He told several different stories. But my dad had also has a finger that got amputated at the tip. So the last digit. And I said, "How'd you do it?" And he said, "Oh, I did it to gain favor into the family." I thought that was pretty funny. I was like, "Oh,
That's awesome.
yeah." All right. Moving on. Sorry. Yeah, so with hyphema, we cover the eye in transport. We want to make sure that we elevate the head at least 40 degrees to decrease intraocular pressure. Okay, this is also to decrease any intracranial pressure, because if there's blunt force trauma that's going to cause that kind of injury to the eye, then we want to have a high suspicion of brain trauma. Okay, and so decreasing the ICP is also what we want to do, intracerebral pressure. And then we want to make sure that we're discouraging our patient from any activity during transport, sitting up, moving around, looking at things. We want to discourage that. All right, so here's that orbital fracture that's also a blowout injury. So you'll see this is a normal orbit right here, and this is, oh gosh, I'm not gonna be able, this is like your turbinates and everything. But this here, the orbital floor has fractured, and now all of this is coming out into this space. This is why I'm not a doctor, you guys. Okay. This requires immediate transport because there's a fracture to the orbital floor. Things are going where they shouldn't be going. We want to cover both eyes to prevent tracking. Okay. Retinal detachment is painless, but it can produce some abnormalities in the vision, like flashing, specks or floaters in the vision. This is immediate medical attention. It may be painless, but as soon as your patient calls and you're like, oh my gosh, this is an immediate situation to preserve their vision. Okay. Most commonly seen in sports, particularly boxing, but any kind of contact sport, really. All right. Any eye injuries following head injuries? If you see unequal pupils, a disconjugate gaze, that's where either one eye stays in place and the other one wanders, or they go in different directions. An inability to track, to follow your finger, any blood under the conjunctiva, or a protrusion or bulging eye, we want to suspect a head injury. Okay. Make sure we're covering the eyes with a moist, sterile dressing. If patient is unresponsive, keep their eyes closed with clear tape if needed. If injury is a result of an explosion, treat injured eye according to protocol. Okay, if there's an impaled object, a burn, a fracture. But we never want to force the eyelid open if there is bulging or bleeding. Okay. If you have a patient who, has some debris in their eye and you're like, I need to open your eye to flush it, we're going to force the eye open. But if you see bulging or bleeding, we're going to leave it alone and we're going to transport. Okay. Because you can cause a whole lot more damage by doing that. Okay, contact lenses and artificial eyes. We never attempt to remove a contact lens if the eye is injured, except in cases of chemical burns, because our objective is to stop the burn. And if we leave that there can be chemical underneath the contact lens that is maintaining contact with the eyes. So that would be a situation we would take it out. With a hard lens, which not many people have anymore, that can be taken out with a mini suction cup. I don't carry a mini suction cup, but a mini suction cup with a drop of saline on the end, stick it on the contact lens and pull it out. It's going to get your hard contact lens out. Soft lenses are much more common nowadays. We're going to place 1 to 2 drops of saline in the eye. We're going to use our gloved fingers to softly pinch the lens and remove. I also find that Q-tips kind of work pretty good. If you take a Q-tip and you just kind of lift the eyelid and you can kind of move it so that now it's not directly against the surface of the eye, and it develops its own kind of fold, and then you can remove it that way. But potato, potato, tomato, tomato. Okay, we're gonna try and place the lens in a container to avoid damage to the lens. Honestly, try your best, but it is not the end of the world if you don't. So sometimes there aren't enough of you to be doing everything that the patient needs. That is one of the most minor things. If you do have the hands and you have the time, then go ahead and do it. You know, find something to put it in with some saline for the patient to have later. But make sure your priorities are straight. Inform the ED if the patient has contact lenses. And then we're going to assume an eye is artificial if it doesn't move like an eye, it doesn't react like an eye, it doesn't look like an eye. Typically, they won't track like a normal eye will. The pupils aren't going to react to light like a normal eye would. And sometimes you can, if you look closely, you can tell it is artificial. Okay. Ear injuries. These don't usually bleed much, but if local pressure doesn't stop the bleed, use roller gauze. When you do that, make sure that you place gauze behind the ear, or in between the auricle and the scalp, in order to support that when you do wrap it. Because if anybody has had ill-fitting headphones that pinch your ear against your scalp, that's quite painful and extremely uncomfortable. So we want to make sure that we make our patient as comfortable as possible. If CSF or blood is seen, we want to make sure that we loosely wrap the dressing, okay? This has to do with your intracranial pressure. If it's seen, then there's an injury in the brain. If it's a closed fracture, then that pressure is going to build. And if the ear is the only way that anything is escaping, that the cranial pressure is able to lower, we don't want to cut off that pathway. Okay. So loose wrapping, but use your best judgment. Okay. If the pinna is partially avulsed, we are going to realign the ear and wrap it. If the pinna is fully avulsed and you don't happen to have the Lord to reattach it, it's just a little Bible joke for you there. Anyways, it's hard when you guys are on Zoom and I can't hear you laugh at my jokes. I just assume that you're all laughing and thinking that I'm funny.
I'm
So
laughing in real life, I promise.
you're laughing in real life? Yeah, well, thanks. I appreciate that. All I hear is silence on my end. So, oh, the emoji. Isaac, thank you. I appreciate it, you guys. We're going to treat a fully avulsed pinna like we would any other amputation. We're going to wrap it in moist sterile dressing, put it in a plastic bag, label it, keep it with the patient. Do not put on ice, but we do want to keep it in a cool environment as best we can. And then, of course, we do not remove impaled objects. Signs and symptoms of a perforated tympanic membrane, loss of hearing and blood drainage. I actually didn't have either of these things when I ruptured my eardrum. The hearing was different. It was definitely distorted and weird. There wasn't any blood, and there really isn't. It has to be pretty severe for there to be blood drainage and loss of hearing. But in less severe cases, you're not going to lose your hearing, and there isn't really going to be a ton of drainage. And the pain is a split second, and then there's no pain. It's not painful. And then typically, especially if it's perforated on the edge, it will heal on its own. Did you know that eardrums are like, I say made, but like their structure and their construction is made to rupture. on purpose. So that way you're not doing damage to the rest of your ear. So yeah, fun fact. Yeah. All right, neck injuries. We're almost done, I promise. All injuries to the neck are serious and considered life-threatening, okay? If it's blunt force trauma, we're going to suspect injury to the larynx and the trachea, as well as the cervical spine. Once the cartilage is damaged, it does not bounce back to its original shape, okay? Talking about your larynx and your trachea. And so we need to be aggressive in treating our airway. This can lead to voice loss, dysphagia, which is difficulty swallowing, airway obstruction, even depending on how far it was crushed, and then air leakage to the surrounding soft tissue, which is going to cause your subcutaneous emphysema. Okay. If there is subcutaneous emphysema, we can feel that when we're palpating the neck or the soft tissue surrounding the neck. We want to make sure that we're maintaining the airway and we are transporting immediately. If air is introduced to the circulatory system, that's going to cause really, really serious problems that can kill your patient quite quickly. Paramedic support, they can intubate your patient. They can also do emergency cricothyrotomy. Anybody heard of an emergency cric? Yeah? An
There
emergency cric is where you
Idaho recently at a restaurant by a doctor.
You what?
There was one performed in Idaho by a doctor in a restaurant, like movie style, with a pocket knife.
Oh my gosh. That's insane.
I'll send to the chat the link to
The chat.
was
Amazing. We're gonna have all sorts of gross pictures and
weird.
videos. Yeah, so that cricothyroid cartilage that's in between your thyroid cartilage and your cricoid cartilage, or not your cricothyroid membrane. There it is. They slice into that and they place a tube. Okay. It's a whole thing. That's why only paramedics can do it. Throat injuries may indicate cervical spine injury, so spinal stabilization protocols should be followed. Okay. Penetrating neck injuries, there is so much blood. These are huge vessels. Some of the largest vessels in the body are these ones. I'm sure we've all heard of this
You may
video.
think that what I'm wearing right now is
Can you guys hear that? Yeah? Okay.
soft body armor. And I don't blame you because it looks like
Well,
soft
looks
armor.
like we're gonna
It
have to.
feels
No,
like
no, no,
soft
wait,
armor. It has
Haha.
Captain by Barger, there's a long shot. Reno makes the save of his pocket front. Pinball, jump to the rebound, but it's stopped by the left pad. Here's Barger sending it back in front now. Comes back to the line, gets it by Cruz. Now recovered by Lauder, gets it back over the line. Here's the pass.
So watch this goalie here when they boom. Now, you see that? Blood.
That is the, oh God. Oh, please take the camera out the building and bring it over there. Please. Oh my God. Just keep it away. Oh, it's terrible. Oh my God, what happened? You're watching Sabres hockey and the microphone here, Sports.
Do you guys see it? So right here,
That's a lot of blood.
so much blood. Okay. So they crashed right there. And in that crash, someone's skate severed I think his jugular vein. And you saw how quickly so much blood made its way onto the ice. I think their physical trainer, this guy, or their athletic trainer, was a war veteran of Vietnam, I think. And basically he went in and he basically went in and I don't know how to make this go back. Oh, that's where it is. He basically went in, stuck his fingers in the vessel and left them there until they were able to get him to the hospital, and this guy lived. So he lived because of the quick thinking of the trainer. There was another hockey player who I think his carotid was severed and he ended up dying because that bleeds a lot faster than and a lot more aggressively than anything else. Why is this not full screen anymore? Full screen. Ah, there we go. Okay, so your penetrating neck injuries are going to cause a lot of bleeding because your carotid arteries and your jugular veins are there. There is a possibility for an air embolism. Our neck wounds get an occlusive dressing, okay? And we want to make sure that we are aware of swelling and hematomas. The other thing is when you are stopping the bleeding, before being able to use an occlusive dressing or anything else, do not check the pulse on the other side, because what are you doing?
Cutting off all blood supply to the brain.
Yeah. Yeah.
You're cutting off all the blood supply. Already half of it is gone. But if you use the other carotid to try and feel a pulse, then they are getting no blood supply to their brain. And that's no bueno.
So you're saying no tourniquet then? Gotcha.
Yeah, I know. I know. It'd make a lot of things a lot easier, you know? We could use tourniquets on the neck. Apparently, unfortunately, it's for our appendages only.
Well,
Okay.
I mean, tourniquet on the neck, if you stop the heart, you stop the bleeding. So success?
Yeah. Honestly, they don't bleed out if they can't bleed at all. So
Mission failed successfully.
I know, so beautifully. Okay. We want to make sure that we are applying pressure above and below the penetrating injury in order to stop that bleed. We're obviously not going to remove the impaled object. We're maintaining the airway. We're maintaining C-spine. We're providing oxygen. We want to make sure that we're obtaining vascular access with all your traumas. I'm pretty sure it's blanket protocol that you get 2 large bore IVs. Okay, that's 20 gauge or bigger on your patient who's experienced a trauma. Okay, and transport really fast and in a timely manner. Okay, penetrating neck injuries have so much room to go south if they haven't already. Okay. All right, laryngeal injuries. Penetrating or impaled objects to the larynx should not be removed unless it is interfering with CPR. Okay. Honestly, if you remove it, you've got an emergency crike. But I'm not a paramedic, so don't take that seriously. Make sure that we're stabilizing the impaled object if it's not impeding the airway or CPR. And then we're going to continually reassess for swelling or secretions that may compromise the airway. Okay. Signs and symptoms of larynx injuries are respiratory distress, hoarseness, pain, dysphagia, hemoptysis, cyanosis, pale skin, sputum in the wound, subcutaneous emphysema, bruising on the neck. Okay, there's a lot of signs and symptoms of this. If you don't see it, you're kind of dumb. So, okay. So let's just make sure that we're aware of our airway injuries. Okay. Treatment and management of laryngeal injuries. We're going to provide oxygenation and ventilation. We're going to apply cervical immobilization. We want to make sure that we are alert to the need for frequent suctioning. Okay. Make sure that you have access to all the suctioning. Don't delay transport. And then we're calling for paramedic backup for advanced airway management, especially if the patient is apneic. Okay. Muscular injuries, non-penetrating are classified as sprains and strains. We've heard of these. These are pretty not emergent, but not meant to be ignored either. Okay. A sprain is the stretching or tearing of a ligament. A ligament is what connects a bone to a bone, okay? So strain is the stretching or tearing of the muscle or tendon, okay? The tendon is what connects the muscle to the bone, all right? So that's the difference between the two. Your strain is also going to be whiplash. That's what whiplash is, okay? So a sprain is the ligament, strain is the muscle or the tendon, okay? We want to make sure that we visually inspect for signs of soft tissue injury. If musculoskeletal injury to the neck is suspected, we're going to address the airway and oxygenation needs if there are any, okay? We're definitely going to try and restrict their range of motion. Sometimes that's with a C-collar. And it's not necessarily necessary for spine stabilization so much as it is to try and remind them to not move their neck or move their head or move around at all. So restricting that range of motion is important so that we don't exacerbate the injury at all. And then we want to make sure that if we're applying a splint, like a body splint, we're checking for PMS before the splint is applied, okay? Which is pretty standard. Helmets, face shields, mouth guards, and safety eyewear help to prevent injury. I cannot stress that enough. If you are in a fight between yourself and a car, you will lose every time. Okay? Please exercise caution. Have your head on a swivel. If you are on a bike or a motorcycle, or a scooter or a longboard or anything that moves faster than you walking or running, then a helmet is a really, really, really good idea. Okay. Using your face shields, your mouth guards. We showed you that video of the hockey player. That's why they have neck guards, the goalies do. I don't know if anybody watches hockey here. My house, we're big Red Wings fans. So because we're all from Michigan. Woo! Anyways, Red Wings. And hockey, yeah, hockey players always wear, their goalies always wear neck guards, and that's why, because of those injuries. So, okay, the end. Yay! Amazing job. I want you guys, let's take a really fast, like 3-minute break, so that we can make it through the last slide. Unfortunately, the last slide are the boring slides because I lost one of my PowerPoints again, but I found out why. So hopefully it won't ever happen again. But 3 minutes. Let's reconvene at 14:23. And then we'll bust out that last one and then be done for the day. Okay?